Compared to the past, the practitioner and hospital are being made more involved in the patient care management. If you didn't document, you didn't do it. And when questions will arise, and it helps even in monitoring the work that one is doing, documentation really helps. Very, very critical, documentation and consent. Whenever you treat, either get verbal consent or written consent. Even where a patient declines treatment, it should be documented that they were given that option, but they opted out of it. Yeah. Professionalism, in their dealings, either with their patients, relatives, colleagues, and everyone. Yeah. Be very professional. Yeah.
Welcome to Daktari Tone, where voices, perspectives, and sounds relating to healthcare practitioners and matters health are amplified. This is a podcast by Daktari Online, created for healthcare professionals across Kenya. Each episode brings you honest conversations, expert insights, and real-life stories from the front lines of care. Welcome back to the Daktari Tone podcast. With me, I still have Dr. Kariuki David, the CEO and Registrar of the Kenya Medical Practitioner and Dentist Council, KMPDC. In this session, we're going to talk about what facility owners and practitioners need to know now and next. So we're going to start with the new National Social Health Insurance, that is SHIF. And there's still a lot of confusion and still a controversial topic around the transition from NHIF to SHIF structure. So in your own words, what has changed and what hasn't?
Right. Yeah. What has changed, one, is that there is a new way of doing things. Under the National Health Insurance, they had what they were calling the national, coverage or super cover. Right now we have the Social Health Authority, Taifa Care. So there was a change in laws. The current law is that every Kenyan is mandated to have insurance. So it's mandatory to have insurance. I think this is the country's maybe vision to ensure that people get covered financially for when they require to get services, because sometimes health emergency events are not predictable. So it's a good thing to have, prepaid insurance like what the Social Health Authority or Insurance Fund aspires. So the other thing that has changed is that there is now more use of digital technologies, especially linked to health financing. And one of the things that has happened is that now, compared to the past, the practitioner and hospital are being made more involved in the patient care management, where previously, maybe it was not always necessary for a practitioner to be involved directly. Now it is mandatory. There is no patient who can be admitted without a practitioner authorizing, providing the pre-authorization request.
Even that reminds me, just to somewhere, I believe a few months ago, we had the clinicians complaining, for lack of a better term, that they cannot be able to deal with the patient, and they in fact have to now use someone else's, especially those who are now under the KMPDU. Like the doctors and that was resolved, right?
Yes, and and as you've said, that's another thing that has come that is new, that everyone is being asked to stay within their scope of service. Now you may not be able to provide, like myself as an obstetrician, I cannot pre-authorize a neurosurgical case because my registration, It's a good thing. Yes, and that's why that complaint had come, because there were professionals who wanted to pre-authorize maybe things that their scope was not allowed.
Actually, that brings in the topic of the fact that we have like maybe facilities that are only based by clinicians, and now they're not able to now surpass some.
Right, so then it would mean they will only provide the primary healthcare that is allowed without pre-authorization, which can include minor surgeries, stitching cuts, such, providing, minor ailment treatment. Yeah, so which is a good thing for the patients. Yeah, it's a good thing for the patients that they will get treated by the right, the right professionals.
Now you've talked about what has changed. Yes. What now hasn't changed?
What has not changed is that, you see, like the registration, licensing and such, that has not changed. In fact, what is happening, it has become integrated. Yes, now we have an integration through the digital systems of the regulators, who are the primary providers of information, through the digital health agency is the intermediary to the social health authority. So remember, in Kenya, apart from doctors and dentists, we also have nurses, we have laboratory personnel, radiology, pharmacists, all these with their different regulators. So all these regulators are giving their information digitally to something called the health worker registry at the Digital Health Authority. So if you are a health worker and you are not registered in that health worker registry, you are not able to provide any treatment for a patient who will be paid for by the social health authority. So that's something. What has not changed is that you still get registered by your regulator, but that regulator passes the information to the Digital Health Authority, who then now provide it to the social health authority. Yeah.
And now, since this transition has happened, I believe, under still your leadership, how has it strengthened, the KMPDC's role?
Yeah, of course, we have now been able to find out more about where practitioners are, those especially in the public sector who maybe are covered in terms of professional indemnity by their various county governments, because those are government entities, were sometimes not even renewing their licenses, knowing that they will not work in the private sector. Now it is mandatory for them to. So some of the people who we could not account for, now we are able to account for them because we know where they are. Health facilities, the same, because even the health facilities, we have them in the health information exchange, the digital exchange. So we are able to also know where they are and who is working in them somehow.
And now, according to you, what are the biggest pitfalls that, delay empanelment or reimbursement, especially for the small clinics?
I think from what we understand is the claims, management and the authorization and the claim, verification exercises where maybe delays are coming in. And I think part of what we have also had that may be a challenge is that maybe people are delaying in either making their payments or such, so maybe causing a bit of delays.
And what do you think practitioners? What do you think practitioners complain more about that is actually within their control?
Documentation. Yes. So because if you do the right documentation, then even the verification process gets faster. So, like if you miss out some information that is critical to the person paying, then there will be delays and a back and forth between the practitioner and the person paying. Because we've seen instances where at the beginning, there were delays even in the pre-authorization process. So practitioners were feeling like there's a lot of delay in patient care. But from what we hear currently, maybe some of the pre-authorization is actually nearly immediate or within a short time. The doctor can discharge a patient, and in the next few minutes, the system has already, authorized that discharge and closed that treatment. Yeah.
Okay. Now, you as a regulator or registrar, between paperwork and inspection, which one is the most toughest?
Inspection is tougher because you'll find the person being inspected is trying to justify, especially where they may have some gaps, and justifying why they have gaps. But because we have standardized tools, we do not, I think we do agree with them, convince them that is actually a challenge. And the challenge is not about them, it's about the person receiving services and what we would expect. Yeah, because when they are minor, that we all agree they are minor, but there are major gaps. Like if you don't have infection prevention, good infection prevention practices, then you already are a risk rather than, a good provider of services. Just as an example.
And as of today, what is that one thing that you would advise a clinic owner to always double check?
Quite a number of things. One, the tools, have the right tools so that you are always ready. If they are working, then it's good for you and for your patient, and you'll avoid pitfalls. Number two, document everything that you do. If you didn't document, you didn't do it. And when questions will arise, and it helps even in monitoring the work that one is doing, documentation really helps.
Mm-hmm. And what is that one most avoidable compliance mistake that the practitioners can avoid?
Not being licensed. Yeah, because actually it does not matter how much you have within your facility. If you did not license yourself to operate for that year, is the first reason for closure. If you don't have a license, we actually do not proceed with inspection. Yeah. Yeah. Okay. That's what usually happens. Yeah. Actually, like you see, because if a doctor is brought before the council on a disciplinary case, if they were not licensed for that year, they lose the case even before we start listening, because then this was an illegal service. Yes, because by law, having a license means you are saying, even this year, I am going to be undertaking.
So license has to be renewed
every year. And the license is valid from the 1st of January to 31st of December. Yeah, so in the event you are found without a license, then you are liable, because then you are providing services illegally. And the patient in that case is right. One, because for you to get a license, you get what we call CPDs, continuous professional development. So we are sure you are keeping up to date with what is currently happening in your field. But if you don't, then you probably did not do that. Yeah.
And with what you've just said, that even when you're now in the hearing, when there's an issue that has a reason, and you start from if this doctor or this clinical or medical practitioner has licensure, it's renewed. If not, the case is just already lost.
Definitely at the end,
yes,
that will be a major determining factor.
And so that means you do agree with me that when systems fail, of course, that leads to legal consequences. Yes. That will, that will often follow. And now we have the case of where now medical legal cases are rising. Why is it so? Why do you think that the medical legal cases are happening?
There could be many reasons, but we find key among them is the increased awareness. The public has become more aware. So the people we are treating are not the people we were treating 20, 30 years ago. This is a community. Remember, technology has increased. Access to media, access to Google. So even Dr. Google has become one of the... Yes, So you find that with that increased awareness, people get from sources that, there's a place we can ask questions. Yes. We can actually go and get answers. So one is increased awareness. Of course, the population has increased, so it's expected that because of population, you will get more, a slightly increased number of questions. We believe that actually we don't receive all complaints that we would have, maybe would have reached us. Yeah.
So for a fact, of course, now awareness, and then the fact that the population is also growing, technology is improving. Now this, brings...
So that multiplicity of factors, yeah.
Okay. And now what are the top 3 things, according to you, that practitioners must never compromise on?
One is their ethics. Yeah. Always do the right thing. Always do no harm. Because of your knowledge, you shouldn't take advantage of the patient. Where decisions have to be made, they must be very objective. Yeah. So, one is ethics, professionalism, in their dealings, either with their patients, patients' relatives, colleagues, and everyone. Yeah. Be very professional. Yeah.
Okay. Third one? Got ethics.
Oh,
yes.
Yeah, ethics, professionalism, and communication. Yes. Yeah, because we realize that most of the cases that we have even handled at the council, at the end of it, the patients and their relatives say, had we been informed of all these things by the time we were leaving the hospital, we would not know where the council is. Yes. But now we had to come to the council to get the answers we have gotten. So communication with their patients is very critical. And communication, and it gets documented. Yeah.
So documentation is also in the list.
Very, very critical, documentation and consent. Whenever you treat, either get verbal consent or written consent. Make sure you're not treating anyone without their consent, accepting that, yes.
That you can now go ahead and do this.
Because the moment you greet a patient and they get into your office and you start greeting and, they just start saying what brought them to you, you've already developed what we call a patient-doctor relationship. Yeah. And from there, many things can happen. Yeah.
Okay. And now what is that one medico-legal mistake that is completely unavoidable but yet very common?
It's documentation. People don't document what they do.
I'm cutting across from the beginning of this conversation.
Yes.
Is this documentation?
Yes,
what is wrong? What is happening in our...
I think people are in a hurry. Maybe, I don't know whether it's hurry.
The fact that right now we are now from paperwork, we are now in digitized. I feel like things must be easier now.
It should be, but I don't know whether it's workload. I wouldn't say it is workload, but I think people do. And once they are happy that they have left their patient well and better, they do not put it down that they have done good work. Yeah.
And is it ignorance? Is it just because if you've already excused, it's not workload? So what really is the main reason why documentation is an issue in our hospitals? I think it's just
habit, and it's good to have that habit that one documents everything that they do. Yeah. Even where a patient declines treatment, it should be documented that they were given that option, but they opted out of it. Yeah.
So what is the most underestimated legal risk?
The most underestimated is what we call professional indemnity. Because as we do good, sometimes questions can be asked of our our work and what we have done. And there are times when you might find that when a patient complains, it actually becomes true that there were gaps in the management. And those gaps can come from the documentation we have just mentioned. But now that we don't have it, we cannot prove that you did it, even if you did. And from that, and it is proved that there is merit in the patient's complaint, and they are the only ones now giving evidence, and you are not able to defend it, you find that it is said there was merit in so-and-so's complaint.
Maybe I should not just assume this documentation is well versed or well known. If maybe you could turn down to what does the documentation entail from the patient's perspective and also from the clinician perspective.
You see, well, documentation from the clinician perspective is that for every client that you see, you must record their name, those demographics. Who are they? And what were their chief complaints? And what were your findings? And what was the plan of treatment? And was that treatment, given or not given? And was there further follow-up? If procedures were to be done, is it documented that the patient consented? And it is what we call an informed consent. So an informed consent, let's say for an operation, would include what are the risks of the operation, what are the benefits, what will be expected after the operation, what are the complications that can occur, there will be anesthesia or no anesthesia, what can happen to it, and all those things. If you're required to do a different operation while operating, have you taken consent that we may end up doing this or the other, such things, all that. And once that happens, then now that is the documentation we are talking about. Then the post-operation follow-up and all those other things that may be required over time, all that's what we are calling documentation. To the patient is the discharge summary. So how comprehensive is the discharge summary that you have given? Is it theirs? So the same things, the name, age, hospital, what was the diagnosis? And there can be a diagnosis before admission and a diagnosis during the admission, because you investigate and what you thought was malaria was not malaria, was something else. All that needs to be documented, and those are the questions that eventually they ask.
Okay, now talking about now consent, what is that one sentence that every consent form must contain?
That largely that it is informed. Yes, that when you have told a patient, we are admitting you because of this, they say, yes, I understand what it is and why we are doing it here. And I have accepted.
Now, in defensive medicine, necessary evil or myth?
It's more of a myth, because there's nothing that people do that shouldn't have been done. And it's largely, I wouldn't call it defensive. I think it's, quality. Quality means that you have looked for everything that you should have looked for before you reached the final decision. So it may look defensive when you do so many investigations and such, and that's why we tell people use available national or international guidelines when treating, so that you can justify everything that your one is.
Okay. Now we've already now touched on practitioner, clinician, and before now I go to now facility licensing and inspections. I would like you to ask me a question or two questions.
Maybe the first is, what do you think I've not yet said among all you have asked that I may need to?
Actually, you're almost you're almost missing something, but then you said it. The part where I asked about the 3 pointers, you even added more to 5. That was ethics, and then professionalism, and then you added consent, documentation, and I really like the fact that later you now added the 2 other vital parts. So generally, you're doing so well. You're to my expectation at least, and also you're adding more to, of course, with this interview was having like prior understanding, but then you're giving me a wide scope of understanding.
Okay.
You're almost taking me to the part of being a health manager as well.
Sure. So do you think defensive is a myth or?
For me, I do believe it's a myth. It's a myth, but then also talking from now, because I am not a practitioner, I'm the patient, so it can be a little bit of, a give and take, where it depends with who you're dealing with. Yeah, because
And
those who have
normally
good
we say
intents.
that most of the treatment should be is a shared decision between the doctor and their patient. Most of the time they agree that, yeah, I can tell you you need 5 tests and you can ask me why for each of them.
Yeah.
Then finally I tell you, then let's do these 3. And the doctor will accept, but they will document that of the 5
we did
which were necessary for me, my client decided on these 3 for their reasons, and I went with them.
But I do like the fact that right now we also have, patient awareness, because if I was to compare with the ages back then, when I used to be younger, we go with books, the doctor will just scribble things, you just follow without asking questions, and you get, right now I feel like the issue of even misdiagnosis has reduced than back then because of this case. And of course, it will come with those who will like the fact that now we can ask questions in the hospital, who will be like, why do they know so much? But again, it also saves time and all that.
It saves time.
Yeah. And now this brings us to the end of this segment, before we now get into now facility licensing, inspections, and compliance.
Right.
And for this session, I really hope that you've got to learn something. And if you're a practitioner or a clinician or of course, overall a practitioner, please get your license. See you next.
Right.